So laparoscopic myomectomy, a systematic review of 6 randomized controlled trials comparing laparoscopic and open myomectomy in 576 patients found that although laparoscopic myomectomy was associated with longer operative time, approximately 13 minutes, it was also linked to less operative blood loss, fewer overall complications, reduced post-operative pain, and faster recovery. Usually this 30 minutes longer time, this is because when we use the morcellator, we take a lot of time to put it into the endo bag. So basically, it is not we are doing the surgery on the patient that time, but obviously the patient is under GA because we are putting it in the morcellator and all. So obviously there is this 13 minutes lag usually happens in the surgery when we are doing a total laparoscopic myomectomy. So how we do appropriate pre-operative patient counseling? In this case, to define a patient's goal from surgery. So first and foremost, we need to define the goal of the patient surgery and to establish reasonable expectations following laparoscopic myomectomy. You need to discuss everything with the patient at length. At length means you need to tell them that what all are the expectations if we are doing this laparoscopic myomectomy, because many times what happens, the patient has multiple fibroids and the patient thinks that all these fibroids are going to be removed. So believe me, it is not possible to remove all the smallest fibroids when we are doing a laparoscopic myomectomy. Basically, you have to remove as many fibroids as it is causing problem with the cavity if you are doing a infertility patients. If you are doing a normal gynae patient who is having menorrhagia, you try to remove more of the big fibroids because there are many small fibroids which are forming, they are ongoing. So they are in the cavity, they will remain in the cavity. If you start targeting them, then you will land in major trouble during the surgery. So you have to give the patient very reasonable expectation because the patient will go and get the scan done after the surgery. He will go and see what is the length of the scar, what is the healing, what is the fibrosis. Believing all this happens, the patient does like this. In general, the intent of uterine myomectomy is to improve, not necessarily eliminate bothersome symptoms attributed to uterine myomas. So I have written it very clearly. It is going to improve. It is not going to eliminate. So this you have to tell to the patient when you are getting the informed consent. The risks of laparoscopic myomectomy should be emphasized, including perioperative blood loss, possibly necessitating transfusion, post-operative adhesion formation, which may yield pain or subfertility, and the rare need for hysterectomy if unexpected pathology or uncontrollable bleeding is encountered. You have to be very particular about taking this consent for hysterectomy, believe me, because the rules tell us, the law tells us that without the female signature, you cannot do a hysterectomy, even to salvage the life of the female. And the female is under general anesthesia. So obviously you cannot wake up the female and take the sign. And you cannot do the hysterectomy on the husband's signature. So please do document it whenever you are going for a laparoscopic myomectomy. And you need to tell them that there are possibilities of future myoma recurrence, which you cannot predict. You cannot predict that when this myoma is going to come, because the patient gets the scan done after 3 months and they have again a myoma in the cavity. The chances of intrapartum uterine rupture when the patient gets pregnant, you have to document everything very clearly. So the preoperative considerations for patients undergoing laparoscopic myomectomy. So what do you do if the patient has come to you with menorrhagia? The patient is already having anemia. So preoperative is the best time. If you know how to do surgery also nicely, but you have not done the preoperative workup, believe me, you will land in deep trouble. So if the patient is having anemia, please do give intravenous iron. Give gonadotropin releasing hormone agonist, because according to a Cochrane review, hemoglobin levels rose by 1.3 gram per DL in women who had fibroids treated with a gonadotropin releasing hormone agonist for 3 to 4 months. Ulipristal is also given nowadays. So it is 5 mg per day for 13 weeks. That also increased hemoglobin levels by 4 gram per DL in women with heavy bleeding caused by uterine fibroids. Obviously, ulipristal is a good drug. And if you are planning not to use the eggs of the patient, because many times the oocyte is also on the borderline level, so you can easily give ulipristal. Patient is going with donor-rectin after that. Surgical blood loss. 2 hours before surgery, have the patient insert misoprostol 400 microgram intravaginally. This induces myometrial contraction and compression of uterine vessels. This reduces surgical blood loss. So I mentioned it very clearly that anything that you're using, why you're using it. So misoprostol, you're inserting intravaginally just to induce the myometrial contraction, because it will lead to less surgical blood loss. On entering to operating room, IV tranexamic acid 10 mg per kg, that also reduces bleeding. So you have to keep all these things in mind when you're taking the patient for a lap myomectomy. Pain and inflammatory reaction. 30 minutes before surgery, give celecoxib 400 mg with sip of water. Provides preemptive pain relief. Celecoxib also decreases inflammatory reaction to surgery. So trocar placement, you see, this is the port placement for laparoscopic myomectomy based on position and size of the fibroids to be removed. So illustration shows 2 ports placed on one side of the patient for suturing. These 2 ports we place for suturing one side of the patient. A 12 mm port placed approximately 2 cm medial to the iliac crest for suture access, and a 5 mm port placed medial to the 12 mm port near the level of the umbilicals for fibroid removal. So we put this for the fibroid removal. This is the male trocar. From here only we will take it. So what happens? How do you manage the intraoperative blood loss? Injection below the vascular pseudocapsule. So this is the pseudocapsule. Now you're going to operate. So we give 20 units of vasopressin in 100 ml of normal saline. This causes vasoconstriction of capillaries, small arterioles and venules. Use of bulldog clamp. You can see this clamp to clip the uterine artery temporarily. So this is very essential whenever you're going for the fibroid laparoscopic myomectomy. So irrespective of whether you have given the patient GnRH agonist or not, you have to do this. You have to give this vascular pseudocapsule. You have to inject this 20 units of vasopressin in 100 ml of normal saline. Don't ever feel that, okay, I have done everything and I don't need to inject it. Please do inject it. So what are the multifactorial contributions to blood loss at myomectomy and consequences of excessive blood loss? So patient demographics, the age, BMI, previous pelvic surgery. Obviously, if the patient is obese, you'll have more blood loss. Advanced age will lead to more blood loss. Previous pelvic surgery, there'll be more additions, more risk of blood loss. The fibroid characteristics, the location, number, size. If there are multiple fibroids, big fibroids, they will lead to more of bleeding. Medical issues, patient already has anemia, clotting disorders, comorbidities, aspirin, anticoagulant use. Possible prevention interventions. We give preoperative patient optimization. We do a pericervical tourniquet, temporary clipping of uterine arteries. We give vasopressin. We give misoprostol. We give GnRH agonist, tranexamic acid. Oxytocin is also given. Bupivacaine plus epinephrine is given if the patient is bleeding so much. And then there is chemical dissection with Messner. So then how do we go for the intraoperative blood loss at myomectomy? The consequences are anemia, blood transfusion, hysterectomy, poor wound healing, infection, collection, prolonged hospital stay, and death also. It has happened in some cases. We have read articles where death has also happened.